Hi, I'm Dale Sherbeck, and welcome to the HQ, a CHA Learning and Healthcare Can podcast serial where we dive into healthcare issues and topics from the perspective of its people and discuss them with those that are leading in the health system. Together, we'll try to unpack these topics and learn what actions are being taken to innovatively solve them today. So today, I want to talk about value, how we set value, how we measure it, and how does this influence our decisions, including decisions related to funding and people, two things often integrally connected. And specifically, when it comes to healthcare, how do we balance those dual notions of what we spend with what we get? And what is the right level of investment based on our expected outcomes? The focus of the HQ is on healthcare and its people, which at its core means we're often discussing the value of our people. And since we began this podcast, we've had much discussion about how our Canadian health system needs to change, improve, and be transformed. Indeed, Michael Gardam put it pretty plainly that we don't need band-aid solutions any longer. We need to fundamentally rebuild our system. But rebuilding will require both money and a design. And so while governments are listening and are poised to make massive investments in healthcare, the design remains elusive, and many are still trying to figure out what we design and how it will provide citizens and taxpayers with the best outcomes and the most bang for our buck. But Michael Gardam was also pretty clear. We need to figure out what we want first, which seems good advice because in the context of value and rebuilding something, we clearly need to figure out what we want first before we determine our design and start spending on doing anything. So all of this got me thinking about how do we weigh the cost benefits of these decisions and options as we seriously start down the road of a system transformation of healthcare. And in searching for answers, I thought, wouldn't it be interesting if we had a conversation with a health economist and get their perspective on outcomes, design, spending, and what we should be asking if we might make better decisions that would create more value for us all. To have this very fascinating conversation today, I'm joined by Dr. Christopher McCabe, Professor of Health Economics at Queen's University in Belfast, jointly appointed to the Faculty of Medicine, Health and Life Sciences in Queen's Management School. He was previously the CEO and Executive Director of the Institute of Health Economics, a not-for-profit research institute in Alberta. Dr. McCabe has 30 years of experience as a university-based health economist. He trained and worked for 20 years in the UK before emigrating to Canada. His PhD was concerned with the methods of valuing pediatric health. During his time in the UK, he held full professorships at the universities of Sheffield, Warwick, and Leeds. In the United Kingdom, he was the founding director of both the National Institute for Health and Care Excellence, Decision Support Unit, and the Academic Unit of Health Economics at the University of Leeds. He was more recently a professor of health economics at the University of Alberta, where he was appointed to the Capital Health Endowed Research Chair. Dr. McCabe has contributed to a number of standard-setting documents, including the fourth edition of the CADTH Guidelines for the Economic Evaluation of Health Technologies, and the third edition of the ISSC Guidelines for the Translation of Stem Cell Research in Regenerative Medicine. He has contributed to key papers on the reimbursement of treatments for rare diseases. More recently, Dr. McCabe advised the Patent Medicines Price Review Board on the technical issues related to the revision of the regulations for the setting of the price of patented drugs in Canada. He is currently chair of the Royal Society of Canada COVID Task Force Working Group on the Economy and a member of the same task force's Working Group on Healthcare Post-COVID. Hi, Chris, and welcome to the HQ.
Hi, Dale. Thanks for having me on.
Yeah, I've really been looking forward to this conversation, Chris, and for some time. And yeah, I think it'll be very fascinating. I hope our listeners enjoy it as much as I'm looking forward to it. So, on the chance that health economics is a new or unfamiliar or even a bit fuzzy for some of our listeners, maybe we can start the conversation with what drew you to the field of health economics, and what do health economists do, and what is the role of health economics? What does it play? What role does it play in healthcare?
So I think probably like most people who are professionally involved in healthcare and healthcare systems in one way or another, you know, healthcare was important in my life growing up. I had siblings with significant health needs, and I think it kind of it shapes the way you think about what you're going to do with your life and being socially useful, or hoping to be socially useful anyway. And I also quite early on discovered that economics is kind of the way my brain thinks.
Hmm.
I was at school at what would be junior high if I'd been in Canada, and when I had my first economics lesson, and they were asking these questions, and it all seemed like obvious common sense stuff, and it came as a shock to me that most people's brains don't work that way, and that I sometimes only half jokingly say that being an economist is as much a genotype as a profession. you know we kind of can't help the way our brains work, and once you've found a discipline, a profession that aligns with the way you think about the world anyway, and then you found an application of that discipline, a specialty that aligns with what you value, it kind of flowed naturally that
Yeah.
I found my way into health economics. It was a not direct route, but yeah, by the time I was I guess 24, 25, I'd landed in health economics, academic health economics, as a discipline, and I've never regretted it and never looked back. Yeah, so that's how I got there. As to what health economics is for the the uninitiated, it's a really wide-ranging discipline.
Hmm.
So on one level, we have people in the discipline who think about, well, what do we mean by health, and what factors determine health. And it has to be that in those areas, health economics has a strong overlap with the disciplines of ethics and philosophy, and then in terms of determinants of health, with epidemiology. We
Hmm.
bring a slightly different mindset, some different tools, but largely very similar tools with different names to bear on these. And but in other areas beyond that, we also think about things that are distinctly economics as applied to healthcare. So what determines the demand for healthcare and the supply of healthcare? What are the factors that determine that? And how well do markets for healthcare and markets for the supply of healthcare commodities, how do they work well? How should they be regulated, if at all?
Hmm.
Um, you know, the healthcare labor markets are very specialized, as we know. It takes a lot of time and effort to train up a doctor, a nurse, a midwife. So these are, they're not competitive markets in the conventional way. And so that brings some really interesting issues about how to regulate those markets. And then beyond that, we also think about how do we evaluate health systems and how do we evaluate health technologies. Because we're dealing with regulated markets,
Hmm.
the state, in one way or another, has a significant role in designing the system, in planning, in financing, and then evaluating. So health economists are really involved in thinking about, well, how do you design a health system if this is what you want to achieve? How do you evaluate whether it's doing it efficiently or inefficiently? And
Hmm.
how do you finance it? And how well do different financing mechanisms align with different objectives for your healthcare system? So, as I say, a very wide-ranging discipline, and most of us, I think all of us really, specialize in little sections of that. So I spend a lot of time and effort thinking about how do we evaluate especially innovative technologies, and
Hmm.
how do we finance access to those technologies. But the discipline as a whole, much broader than that. I have done some work around workforce issues, so I'll be drawing on that work in our conversation today. But I'd emphasize that I am not a specialist in the economics of health labor markets. I've done some work, but it's not my strength, my major specialism.
Fair enough. And I mean, we're going to try and, I guess, take a graduate level,
Yeah.
program and distill it into a 60-minute podcast. So good luck to you.
Thanks for that. That's going to be fun. I'm really looking forward to this conversation. It's great to talk to people about the things that I love, and I really do love health economics as a discipline, and I love to share its insights and its challenges.
Yeah, it clearly comes through. So I started my introduction by talking about value, Chris. So, I mean, what is your take on value in healthcare? And, is that the right question we should be asking as we start down the path of contemplating the transformation of our health system or health system reform here in Canada?
I don't think there's a single more important question
Mm-hmm.
than value. I also don't think there's a single tougher question than value in healthcare. Value is at the heart of economics as a discipline. And it's where much of the conflict about our discussions around what our healthcare system is doing well and what it's doing badly and how we should change it. Actually, when you get down to where those disagreements and tensions come from, they're often founded in different values about the most important attributes of a healthcare system and what is most important for a healthcare system to deliver.
Mm-hmm.
So, even, people will value different things. And even those people who value the same things in healthcare will value them differently. They'll attach different weights to the same aspects
Mm-hmm.
of healthcare. So in economics, we talk about a commodity, so product, good, service, we call it a commodity.
Yeah.
We talk about a commodity having multiple attributes, characteristics, and we attach some, no, or a lot of value to each of those attributes.
Okay.
And the total value of the commodity to an individual, like myself, depends upon how much value I attach to each attribute and how I combine those attributes. So do the attributes reinforce each other? So is the whole greater than the sum of the parts? Or actually, are they simply additive? How do I combine them? That determines my total value. So that sounds very abstract. So maybe I'll take a simple example.
Sure.
To help people understand how complex this is. I was thinking about earlier today, what's one of the most simple and basic technologies that a health system will provide? And I landed on the walking cane, walking stick, as we call it over in the UK. So what are the attributes of a walking cane? Well, it improves a person's mobility and likely reduces the pain when they're walking. So those are two things it does, two attributes. Owning a walking stick for its own sake is not something most of us do. I mean, there's collectors, but most of us, if we have a walking cane, it's because we want what it does for us. So it can improve our mobility and reduce our pain. So it might reduce the time it takes me to walk to the shops.
Mm-hmm.
And similarly, it may increase the number of shops I can get to walking. And so all of those are things that I value. And they're all attributes, essentially, of the healthcare product of providing a walking cane. But it also is a very obvious signal to everyone around me that I have reduced mobility, and that can change how people interact with me. Okay, then and it may change how I think about myself as well. And now most people are going to put a positive value on the improved mobility and reduced pain. However, I would say somebody with access to a car is going to put a very different value on the reduced time to get to the shops when you're walking, because they don't need to walk to the shops. And they're going to similarly put a much lower value on an increased number of shops that they can walk to, because they still don't walk to all those shops. So it's not making any difference to them than it would, whereas somebody who relies on walking to get to the shops or to public transport to get to the shop, it's going to be valuable to them. So instantly we're seeing a bit of differentiation in the value between two people for the same technology, even if their health state, their need for the walking cane is the same. We can go further and say some people may really resent the outward sign of reduced mobility. Their independence and people treating them exactly like everyone else could be really important. They may view it as a stigma, that people think less of them. Other people might not care a heck what somebody thinks about whether they need a walking cane or not. And someone else might really like the fact that it's a signal to people that they need a bit more time, they need a bit more support, a bit more attention. So we can see negative, no value, and positive value associated with exactly the same thing. So just as a simple example, you can see how this, two individuals in the same health state having the same clinical need for a walking cane can value it very differently because of its attributes that it has and what it means to them in their life state. And so it's hard enough just at that individual level to think about the value of a technology and being confident that this is the value of a technology. Now, if we really want to make things complex, and sadly we don't have a choice, at the system level, when we choose to provide one healthcare service, we are choosing not to provide another or to provide less of it because we can't spend money twice. And we have to make the decision at the service level, the system level, because healthcare has what we call very large economies of scale. So you need, to make a hospital efficient, it has to be serving a large population, tens of thousands of people. A fully equipped teaching hospital will cost as much to provide that full set of services to one person as it will to 60, 70, 80,000 people. So for efficient use, we have to make these decisions at the system level. And so we are, as a system, we're having to make choices about what healthcare services we provide for a whole population. And we are inevitably choosing between competing groups of people who would prioritize if it was just their personal value differently. At the system level, we have to try and say, what do we as a society value? What are the attributes of healthcare that we as a society value? And historically, those conversations, to the extent that they have happened, have been amongst politicians, ministers and senior health system decision makers. But the world has moved on. Our ability to engage in these discussions using, social media, etc., means that quite rightly, lots of people, lots of citizens want to be engaged, want to have their voice heard. And we need to find a way to actually empower the voice of citizens in this conversation about what healthcare systems should be valuing and how much, because once we understand what is valued by society at large, we can make some informed choices about how we invest the healthcare dollars. And we can explain to the citizens why we have made the choices we have. There is no decision that's going to make everybody happy. There's probably not a decision that's even going to make the majority of people happy. So there's this concept of procedural justice, which says, for it to be just, recognizing we will not be able to arrive at a decision which everyone approves of or supports, for it to be just, it has to be evidence-based, it has to be transparent, and the people affected by the decision need to have voice in that decision. And so we need to find ways to give the citizens line of sight on why we've made the decisions we have and the ability to give their views on those decisions and appeal them. And I think that's one of the challenges we have in front of us, moving from a position where it's our democratic leaders and the senior health system executives who are making the decisions about what the health system values, to a position where we can draw a clear line of sight between the views and values of the citizens that are served by the health system and what the health system values.
So very, very interesting. And I think I can certainly see as you describe all of that, why you do bring in, concepts of ethics and philosophy and epidemiology into the whole sort of context of that, so I started the question by asking you, is the question of value the right question that we should be asking? I think you very eloquently sort of pointed that it is. I guess what I would sort of reflect on is that we as citizens or as users of the system often talk about quality, not value. So can you disentangle those two things? I mean, is it the same, or why are we having different conversations perhaps within the population versus the system designers?
Yeah, this is such an important point, and I don't think it's an either or. I think
Okay.
what we need to understand is the relationship between quality and value delivered. So we want the health system to deliver health and other aspects of service that we value, that we have the attributes that we think are most important. The issue of quality comes in to whether the product of healthcare in the individual case, whether it actually does that. And I want to separate out two components. Low quality healthcare can deliver less of the valued attribute than is expected, than the good quality version would, or it carries a greater risk that it won't deliver it at all.
Mm-hmm.
And both of those are a legitimate concern. Healthcare is inherently uncertain. It's inherently risky enough without introducing low quality care into it, increasing the uncertainty that we'll get the benefit we want in ways that are avoidable. And so quality really matters.
Mm-hmm.
If we know how much we would pay, or we'd be willing to pay for a given healthcare that we would expect from a quality process, and that's an if, but it's an empirical question. We can work it out, and we have approximates of these things just through policy making. If we know what that is, then we can start to think about, well, what is the penalty? What is the discount that we would apply for it not being of the specified quality? And so I think thinking about how much we value the confidence that the care will do what it says on the tin as far as possible it is an important thing. And there needs to be accountability. If low quality care is delivered, then there should be accountability. The same, essentially in some form, the same payment. The payment should not be unaffected. So we need to think about how we contract for things so that the incentive for quality is built into the contract, and there is a very clear mechanism whereby there is a financial, ideally a reasonably prompt financial penalty for lower quality care, because we know the system as a whole is probably, is certainly at risk of having to compensate the individual who receives low quality care. So at the moment, maybe we've got a problem where the health system is held accountable. There is a clear mechanism for holding the health system accountable, but there aren't always the same clear mechanisms for holding other actors within the system who are responsible for the quality of care accountable. And maybe we need to think about that. And it's not just financial. I think financial is probably important, but quality is a culture thing as well. And we need to think about how do we incentivize the creation of those quality-oriented cultures. I don't think anybody, I've been working in and around healthcare for 30-something years now. I've never met anyone who comes into this business wanting to deliver poor quality care. I think it's not at the individual level. I think it's much more at at that culture of the team or the institution or even the whole system, that poor quality creeps in, and we need to find ways to incentivize the pro-quality culture in its broadest sense. So they are related, value and quality, but the relationship is quality impacts on the expected magnitude of value and the risk that we won't see any value at all. And that's how I think about the two things relating.
So, moving, I guess, that a little bit further ahead in our discussion, I'm assuming that, like it's no secret to, I think anybody in healthcare and most Canadians, that we're in a crisis in our health system right now. Some may assume that it was a result of the pandemic. I think most will argue that this all started well before the pandemic, and that we are, currently in a health human resource crisis. There's no debating that anymore, and a crisis of the people who deliver the services and run our systems. I guess I may posit, like, is that a failure of people to adhere to sort of health economic sort of principles and understanding of the system that we've ended up in this crisis? And I'll just sort of leave that hanging there, and you can go after it or not. But, our organizations and health leaders sort of continue to bring to the table, and discuss this issue with a focus on, 4 pillars, at least from an HHR perspective, around recruitment, retention, wellness, and then starting to think about either, a failure to use our systems wisely and, models of care and, scope of practice, uses of technologies and things like that, as being both a solution and also a crux of some of the issues that we've had. I guess what I would ask from your perspective as a health economist, are these the right pillars for us to be focusing on? And if so, what lens would you bring to a discussion of each of them?
Thank you. I think what a challenging question. First off, I don't think health economics and health economists can stand on the side and say, well, if you'd only listen to us. I've been in this business for 30 something years. I spent a lot of time talking to policymakers throughout most of that period, actually. So if the health economics voice and insights haven't been used, then I think we as a profession are going to have to own some responsibility that we haven't communicated effectively what we can offer, or we have, not engaged with the real priority problems facing health systems. So we maybe haven't been as useful as we should have been. So, we're in this with everybody else. We're part of the healthcare family. We often say things that our siblings might not like to hear, but that doesn't make us any less part of the family, and doesn't mean we don't have a shared responsibility in here. So that's my first kind of comment there.
So you don't just get to sit on the sidelines and say, I told
you
so.
Even those of us mostly sitting in universities, I think it's kind of the part of the social contract, the unwritten social contract, that when society writ large has issues, questions, and challenges that relate to our expertise, actually, that's when we have to stand up and say, well, this is what I know. This is what I can offer. It's really important, certainly, especially tenured professors like myself, we are protected almost uniquely. And I'm firmly of the belief that protection and the justification for it is that in times like these, we speak up. We say what we know, how we can help, without regard to whether it is popular with those in power. And it's that component that requires this concept of tenure, so that there's people who are experts who can say the politically uncomfortable. And that's, and so in times like this, where there are pressing crises for the health system, those of us who work in this space and have expertise in this space have to offer our expertise up. So anyway, there you go. We're not allowed to sit on the sidelines as far as I'm concerned. Are these the wrong pillars? I think I would say quite firmly no. I think they're very, very good pillars and very important things to think about. But I think sometimes there's a risk that we think too much within the silos of each pillar. So what's happening on retention? What's happening on wellness? What's happening with recruitment? And I think it's more important to think about the relationships. So earlier on, and I was saying, we need to think, when we're talking about value, I was thinking we need to think about what we want the health system to produce. And that fourth model there, that innovative models of care, changing how we do what we do, that's related to this idea of, are we producing the right stuff? And are we producing it as effectively and as efficiently as possible? And I think you actually need to understand whether you're doing well on recruitment, retention, staff wealth. You actually need to, again, go back to this. What do we want the health system to produce? So as an economist, yes, I think of people as central inputs to the delivery of health services and therefore the production of health for society. But the production of health, how do we define health? And what do we want the health services to deliver? I keep on coming back to this, but we can't actually understand whether we're doing something well until we all understand fully what it is we want that something to be. So the first question should always be, what do we want the attributes of the healthcare system to be? And that then tells us or leads us to the question, do we have the right people to deliver that sort of healthcare in that sort of way? So what are the attributes of the model of care that generate the value that we're seeking? And then, okay, if we understand that, what are the attributes of the people that we need to deliver those models of care? So I'm talking about people quite consciously, because I think staff risks us slipping into that issue of thinking about people a bit too much as resources.
Yeah.
I think they're much more well-rounded than that. So you think about the attributes of the people that you need to deliver the models of care, then you can start thinking about the match between your current staff and what you need. And so that will then inform your recruitment and retention policies. If you have the right staff, then that's great. You now need to look at the labor market and ask the question, are you offering a competitive employment package? And again, I think we need to think more broadly, because a competitive employment package isn't defined by us. It's defined by what they are looking for from their jobs. And so that's where we get this relationship between recruitment, retention, and well-being. That there is a feedback loop between these things. If they are getting what they want from the job, they will stay with the organization. If when people look in from the outside, it looks like what they want from the job, when they consult with their peers, because they do, we know, that our labor forces they're actually communities and remarkably close-knit communities. The degree to which they know each other is stunning. And so they can always get what's it really like on the inside story. And so if they like what they hear and they see, then we will be able to recruit. So pillars 1 and 2 talk to the match between your current staffing and what you need to deliver the healthcare, the valued healthcare that you're responsible for. Okay, so if you're not clear about what it is you're meant to be delivering, it's really quite hard to know that you're doing the right thing in you're looking at your retention and your recruitment in the right way, I'd say. Pillar 3 talks to the risk that you might lose the necessary staff you have or struggle to recruit them. And then Pillar 4 seeks to the need to regularly review that question of the models of care that we have. Are they the best for producing the most valued healthcare with the money we have available to us? So all 4 budgets are important, but I think the relationship, sorry, not all budgets, pillars, all 4 pillars are important, but the relationship between the pillars is what we must keep at the forefront of our mind as we go forward, because they are as important as the individual pillars in understanding and I guess looking after the staff, the people in your organization so that they deliver the value that the citizens your organization serves are looking for.
So if I can sort of cut through that a little bit, would it be fair to say that we find ourselves in a crisis of health human resources because we have not created a culture, environment, context which is attractive and welcoming, right? That that we are ending up in this crisis?
I think it was pre-pandemic, it was attractive enough that people would flex. The health system ran on a degree of goodwill, and the transaction costs of moving province or moving to a different job entirely were just too high. What the pandemic did, I think, is it used up all of those reserves that were supporting the flex.
The goodwill.
And so people, that goodwill, and people were understandably were expecting that once we were through the peak pandemic, that the health system would start catching up. And of course, they didn't know, and why should they know? They were getting on with their jobs in their industry. That the health system's ability to flip back and deliver not just at previous volumes, but actually at higher volumes, actually wasn't there because previous volumes had been sustained a certain amount by goodwill, and there just wasn't the emotional reserves left in the staff. There needed to be either a recovery period, or we had to find new staff to boost the capacity just to deliver on the previous levels of activity. But quite understandably, the people waiting for their hip replacement or their cancer surgery or whatever said, okay, the pandemic's out of the way now. Why am I still waiting? I need this. And so we had, I think, taken our eye off the ball. We kind of got used to and normalized the importance of goodwill in the delivery of the health system, and it's come back to bite us. And so as we start to rethink, move beyond the sticking plaster and really rethink how we structure and resource our health system, that design approach, we're going to have to make sure that it's not a production function that has an unrecognized and unfunded goodwill parameter in it, because I think it did. And the pandemic was what it took to show us that. So yeah, we are in trouble because of I guess, sorry, let me say this again. We got in trouble because the essential role of staff goodwill in the delivery of the healthcare system had become normalized, and it didn't show in any of our budgets. And so nobody was responsible for thinking about how it worked and planning forward strategically. How would we, how was that going to play out? And so, yeah, the pandemic brought something very important to our attention, and we're now post-pandemic or post-acute pandemic trying to figure out what we do, because we've used up that resource, and the productivity of the health system is showing the effect of the removal or loss of a resource that was crucial
Hmm.
to the previous levels of output.
Yeah, I mean, the cracks and fissures were there, right? They were overcome, I think, in your words, right, through the goodwill, the commitment of passion and purpose, right? People
Yeah,
truly a vocational sort of calling to deliver compassion and help people, compensated with reasonably good salaries, I
yeah,
suspect, right? That allowed
absolutely.
people to sort of overlook, some of the cracks and stuff until you bring something like a pandemic on, which magnifies those cracks and
Yeah,
pushes people to a point where, you know, my commitment to helping people and the money I'm getting isn't good enough anymore. Is that?
absolutely. Because you can't actually convert money very easily into emotional reserves,
Hmm.
actually. And so when you really have used up all those emotional reserves, the fact that you may have paid them quite a lot of money in that period, they're not in a position where they can just buy emotional reserves. The only way they get the emotional reserves off it back is essentially time away from the job, time away from the coalface. And that's exactly what the health system couldn't deliver
Yeah.
as we moved into this endemic period. And so, it's those that passion and purpose. I think that's a great phrase for what our healthcare professionals bring. It's not something you can buy some more off the shelf.
Hmm.
Those reserves have to be replenished by time away from the job to a degree, and that's kind of our problem now. Our staff need that time away to recharge and to be reinvigorated to pursue their passion and purposes they have, and yet the pent up demand for care is in tension with that, and it's a real challenge.
Yeah, we're in a bit of a contradiction of we need more people to be able to give the people we have more time to be able to
Yes.
replenish those reserves. I am struck by that some of I guess, the intentions of how to fix the problem are also repeating some of the same, strategies that we've seen in the past, which is throw more money at the right,
Yeah.
and not dealing with some of the underlying issues that might be there. And I think many of our healthcare workers are sitting on, probably near record sort of bank time of vacation time that they've not used.
Mm-hmm.
And yet, yeah. So we're, you know, I think as uh, one of my colleagues has said, is that, coffee and chocolate bars aren't going to sort of get you out of this. Um, so. Um, so coming back, I mean, you touched on it a little bit, and I guess the other thing that I'm struck by from one of your earlier comments as we really start talking about the people side of this, that I mean, you define our health system, which I think we often think as well as a health system, right? We don't think of it as an economic system.
Mm-hmm.
We don't, at least I don't. I didn't until a conversation today, thinking of it. It really is a supply and demand structure. And in that we have these people, which are there's a transactional element to that, and we have obviously a supply and demand challenge as we're facing in terms of our current crisis. Our, and I think you corrected it as well, so I won't belabor it, but we do define people in all parts of our economy, right, as human resources, as
Mm-hmm.
resources that are in large part seen as somewhat infinite, renewable. Like we just get more people when we need more people. Um, I'm wondering. So I mean, maybe to package all that up together again, is how would you structure, I guess, that paradigm in terms of how do we view our people in the system in a way which is meaningful and more attuned to the real value that they place within the system itself, that isn't treating them as resources?
Yeah, I think you probably, touched on what I'm going to say. I'll try and unpack it a little bit more, but I think we're probably in a similar space on this. On one level, it's tough as an economist. You were just saying, I'm characterizing the health system as a production system with demand and supply in different markets. And so undoubtedly, people are inputs to healthcare production. Okay. No staff, no healthcare. We know that. That's half of our problem right now. On the other hand, the assumption that they are immediately replaceable, that we can recruit in if somebody decides to leave, that's not true. It never really was true, but it's acutely not true now. And we need to think about what it is that people bring to help produce health and healthcare as members of healthcare teams and healthcare organizations. Now, going back to my undergraduate dissertation, which was around education and training economics, possibly the only thing I still remember is that they talk about general and specific human capital. Now the specific human capital includes, it's not limited to, but includes the knowledge and skills that generate value specifically in the context of the firm in which the individual is employed. Now, healthcare is inherently relational, okay? Delivered by multidisciplinary teams, working in institutions that exist within a system, and overwhelmingly, it's focused on serving one individual at a time. So relationality is central to all of that. How well you work with your team, how well you relate to the individual patient, how well you understand how your team relates to other teams in the institution, how you understand how your institution relates to other institutions in the system. This relational knowledge and the relational skills to work with those relationships, they are specific. They're not captured in anyone's licensure or certification degree program. They exist or are built through the experience of doing. They're driven by context-specific knowledge, and they take time to accumulate. And these teams and institutions have cultures, and those cultures are more or less suited to different individuals. Why I'm going on about this, these are all things that contribute to the productivity, the efficiency of the healthcare team, institution, system. And that means the transaction costs when we lose a member of our staff are not well covered by the cost of recruiting, just the financial cost of recruiting another person with the right certifications and licensure into that post within the organization. They are likely much larger, captured by that. So when we are thinking about the what do we do to retain staff? How much are we willing to spend to retain them? What's it worth doing to retain staff who have the right skills? Just looking at, I need somebody with this qualification and this many years experience using in that profession, that's going to miss it. It's going to underestimate the costs of losing somebody and the value of being flexible. So thinking about the soft skills, the specific knowledge, the social capital within a team that a member has, this should all be reflected in how we manage staff, decisions about retention and promotion, etc., because they all contribute to the efficiency of the healthcare system in producing health. It's not just, I need a surgeon who's board certified in orthopedics I need an anesthesiologist, and I need a theatre nurse and theatre techs. That, how well the quality of what's delivered by that orthopedic surgery team will depend very heavily on lots of relational and specific context-specific skills. And I don't, because we think, and we've used the language of human resources, I think we've gone wrong a bit. We thought we can swap out people with the same skill set and expect the same outcomes. And I don't think we can. And I think in recognizing that, recognizing the individuals as people will actually tell them they're valued. And it's one of the things that we can do to start rebuilding their well-being, putting back some of that passion. And so it's a culture change that we need to make at the system level. When we're thinking about resourcing of the system, we need to change how we think. And it's a culture change that we think about people, not human resources, to make sure we capture the importance of all of those softer and context-specific skills. And I think it really will, I think we will be surprised how quickly it changes how members of teams that are employed in our health systems will feel valued. Because it's really hard to feel valued when you're one member of staff in 100,000. But if the system engages with you as, it's Chris in the health resource analytics team who, has these family responsibilities, but is great at showing flexibility, at working overtime or working weekends when necessary. And it's done at that level with an appreciation that he's had 20 years or whatever in this job. So he knows lots of things that aren't written down anywhere. That will, I hope, change things.
Yeah, but I think, I think there's a lot of brilliance in, I think, what you're describing, because I also think that what you're probably describing is the next calamity that's coming, right? Like that, it's where the puck is going to be, which is like right now we're focused on filling, seats, right? And replacing people without the real appreciation of the full cost of what this crisis is probably waylaid for us. And I'm thinking about, previous to the pandemic, there was a lot of focus on culture building, right? Different facets of what that might be, whether it be about making it more people-centered, more inclusive, more safe, right? There's a whole, set of priorities that people have put in that, but it really was about building culture. And I think that I'm going to guess that the heart and soul of so many of those initiatives has has been ripped out of them, right? That people will be starting again as they start to rebuild teams with different people.
Yeah, sure. Because it's so relational. I think it's natural.
Well, with that positive thought in our heads.
There's a reason they call it the dismal science,
Good to know. You did not come with a warning label. So far, our discussion about health economics has really been through the lens of those leaders and decision makers. What would be your elevator speech, perhaps, to the average lay Canadian with respect to health economics? What questions do you think citizens should be asking about our system and its performance? That ultimately, for those decision makers as they continue to go forward.
This is another tough question. You keep on throwing me these curveballs, but I'll give it a go. So, health economics is concerned with how do we get the most valued healthcare from the tax dollars the government allocates to fund it. As individual citizens, we expect the healthcare that we need to be available when we need it. That's one of the things about healthcare. We don't know we're going to need it until suddenly we do. And when we do, we expect it to be there. But most of the time, we don't need it. And that's great. And as a result, a lot of us don't really think carefully about what we want the healthcare dollars to be spent on until we or a loved one actually needs that healthcare. And then we're very much, I need this, or my mum needs this, so this should be available. And we're advocating for them. We're not engaging with the question, what should the system provide?
Mm-hmm.
So I would ask all Canadians to engage with some easy to say but awful hard to answer questions. What healthcare should be provided on the tax dollar, and to whom?
Mm-hmm.
If we can't have everything, and sadly we can't,
Yeah.
what should we prioritize and why? And more challenging still, but I don't think we can duck it, what is not valuable enough for it to be provided on the public purse? And I would hope that, as we're coming out of this and we're engaging in this redesign, that we can get enough Canadians to engage with those questions kind of all year round, not just when they go to seek care and it's not what they hoped for, but actually to recognize, the importance of setting a new foundation on which we build the next generation's healthcare system, because that's where we are. We're going to sit down over the next couple of 3 years and design the healthcare system for the next 20, 30 years, I expect. And I want Canadians to engage with those really uncomfortable questions so that we get the best possible start, the best possible foundation for this design process.
Yeah. You in terms of designing, right, the supply side of the services, we need to figure out what our expectations are on the demands, right?
Yeah.
Right.
Absolutely.
Yeah, and I agree. Most people don't want to have that conversation. They think that they're, perhaps appropriately, that their needs are always going to be most important. But the question from a social perspective, right, is really what is the state's responsibility for those things?
Yeah, absolutely.
So you've touched on this a little bit in terms of I think your previous academic work, but I mean certainly from my own perspective as a learning and development professional, I think our listeners, I think, have come to expect me to ask these kinds of questions, and I'm certainly keenly interested in them. So I'm interested in both the question of how we develop that supply chain of professionals, and ultimately why we're in this predicament of undersupply. And I will emphasize again, because it's not the first time. And then, secondly, I'm interested, and this relates to my own work, right? Interested in discussing that the knowledge and skills that you describe, right, that creates that value. Ultimately, what we're teaching to these people, that we're developing, the people themselves that will become, part of the solution or potentially part of the problem. Where do you take, that training mix sort of perspective in this, and how does that all flow?
Yeah. So I think one of the fundamental problems is, and this is not at all unique to Canada, is the supply of trained healthcare professionals has been subject to relatively short-term political budgetary issues. And I think it's just the wrong lens. How many medical school, nursing school places can we afford this year is the wrong question, because it doesn't relate to what the demand for healthcare professionals is going to be. Given how long it takes to recruit, to train, the healthcare professionals, almost all healthcare professionals, it takes a while to train them to the point where they're ready for, clinical practice. I guess I would like us to treat it more like a national infrastructure question.
Mm-hmm.
The way we think about, well, what do we need in terms of water utilities? What do we need in what we need for gas? What do we need for electricity? And it's a continuously rolling program of investment that's based on pretty robust predictions about society's need for those services. We're now seeing it with, sort of Wi-Fi and internet. This is now being recognized as a necessary piece of societal infrastructure. Well, the need for healthcare is, I would say, an equally essential piece of societal infrastructure. The staff to meet quite predictable needs. We can look at our population and look at it aging. We can look at how much people need at different ages, and we can make reasonable predictions. Well, if this is the minimum safe staffing level on an evidence base, then we're going to need this many nurses, this many midwives, this many pharmacists, this many doctors, etc. We can take an evidence-based approach to this, but it has to be taken out of the hands of political decision making. We have to take it out of that short term. I mean, at the end of the day, there's always going to be an interface with Treasury, an interface with the finance ministry. But we want it to be as little as possible and really as rare as possible. 10-year settlements, I guess, is what I would like to see. If I could, wave a magic wand and change things, we would have a federal health workforce training commission that was responsible for putting out annual forecasts and agreeing the training places across all the major specialties with the universities, and had the budget to do that, and not here's your budget for this year, but actually no, here's a 10-year budget. We're settled, this is your budget for those 10 years, and then the universities can plan, they can make the investments, and if they've got a 10-year settlement, as we're looking to change what each of the clinical professionals knows how to do, that requires that you change what you teach. Changing what you teach requires investment, upfront investment, that you then get the returns on with the subsequent years of cohorts of trainees. You can't do it if the universities will struggle to do it if they haven't got guarantee that they will see the necessary volumes of students coming into those courses for them to make a return on the upfront investment. And so I think we need to just change the lens. Health system workforce is a national infrastructure consideration. It should be viewed as such. It should be invested as such. It should be protected as much as possible from short or even medium-term political influence, because we're all going to get old. And we're all going to want healthcare professionals and social care professionals and long-term care homes professionals available to care for us, give us a dignified time whilst we need care. And that shouldn't be subject to, were we lucky enough to hit that need at a time of plenty, or we've been unlucky and we hit that at a time of famine. So that's my take on this issue.
Yeah, I think it's again very very wise, and I mean I think understanding that I think even your 10-year sort of horizon sort of window, I think is a makes sense. I mean it's it's roughly the amount of time it takes to develop each of our health professionals, give or take, but those people will be in the system for 30 years, right? Once developed, right? So and if we're always developing them in this sort of boom bust sort of phase of things, we're going to continue to probably foster these cycles too.
Yeah.
So a final question to you, Chris. I mean, we've talked about several of the stakeholders here, and I think you've circled around the one question here about our politicians a little bit in terms of taking them out of the equation. But if we bring them back into the equation, what is the health economic question that politicians and leaders should be asking that they're not, do you think? And maybe from the perspective of both, why are they not asking it, do you think, and why should they?
Okay, so now I'm safely the other side of an ocean. I feel comfortable having a go at this question. So I think the question that politicians and citizens of Canada, and I am one, should ask is health really best served as a provincial jurisdiction?
Mm-hmm.
It imposes massive costs on Canadian healthcare system and promotes inequality. We're just starting to look at maybe a national licensure for
Mm-hmm.
doctors. We need the same for all healthcare professionals. We are we have an approximation of national negotiating drug prices, but it's only if the provinces on a case-by-case basis agree to sign up to the national negotiated. So we pay top dollar prices for drugs in Canada. We struggle to share information between provinces and data. So it's really hard to learn from each other. It's really hard to run research that requires national coverage. So, the UK recovery trials during COVID were possible. They told the world very rapidly that some things worked really well and some things really didn't work and could be stopped. And that was invaluable globally.
Mm-hmm.
Canada could not have run those trials. We don't have a national clinical trials network with all of the infrastructure. We're not even very good at sharing information, linked data sets across the country. There's some, but nowhere near where it should be. We are, because of our provincial structure and it being kept as a provincial jurisdiction under our constitution, there are a whole host of things that we could do better and we could do more efficiently, but we don't and won't because of that jurisdiction. So, and promoters of the provincial jurisdiction say, but what you get is lots of experiments that we all learn from, these natural experiments. But the reality is every other healthcare system around the world is also running experiments that we can work from. So I ask what the marginal value of having our little in Canada experiments really is. I'm not convinced that it's enough to justify the harm, and I use that word advisedly, the harm that provincial jurisdiction does to our health systems. And I think the question is not asked because it would reduce the influence of provincial legislatures. And sadly, and I'm not saying I would be any different if I was, a democratically elected politician. I've never had the courage to do that. But sadly, I would say, most politicians don't subscribe to Aneurin Bevan, who led the creation of the UK NHS. One of his many great phrases was that the purpose of power is to give it away. And our politicians, not uniquely at all, but they find it very difficult contemplating giving up power. But we as Canadians relying on our health systems, I think are harmed by the determination to keep health as a provincial jurisdiction. So there you go. With the ocean between me and Canada right now, I felt brave enough to answer it.
Well, I think drop the mic. I mean, but yeah, I mean, I think nothing is more powerful than a healthy population, right? So,
Yeah.
Right, and I think that's what we're all striving to achieve. And you make a very strong case for the best way to achieve that is through sharing our resources nationally and equitably, cost effectively, as a mechanism to improving that value for all Canadians. Coming back to, I guess, that question I began with. So thank you. This conversation, at least, has not disappointed me in the least. It's been tremendous. I've really, really enjoyed it, taken a lot of learning from it. And so thank you very much, Chris, for spending the time with us here today, and sharing your wisdom, your research, and your expertise on this subject. So thank you.
Thank you very much, Dale. It's been a real pleasure to talk to you.
Thank you. I look forward to chatting with you again.
Absolutely.
Okay. Bye-bye. You've been listening to the HQ, and I'm Dale Sherbeck, your host. You can find this and other future episodes on the CHA Learning website, Apple Podcast, or Spotify. We'd love to hear what you think, so please follow us on our other social media channels. Thanks for joining us in this discussion today. Please join us next time.